First of all, I wanted to show you that I tabulated your results from the survey that I gave at the beginning of the course and last week. These are the 5 stances that I lectured on in our first class. The blue bars are your first test. There were 65 participants, and the orange bars are your last week's result test, the poll results with 48 participants. The error bars represent standard error, which you might not know what that means, but standard errors are smaller than standard deviations, and they function to visually suggest whether or not different bar length or height is a significant difference or just a non-significant difference. So if the error bar includes the height of its adjacent bar, that indicates probably significant difference between the two. So you can see that your resilience and persistence, not individually, but as a class, has increased over the course of, let's see, how many weeks? That's 13 weeks. So that's a good improvement and good for you. Now, that's not to say that all of you improved or those that improved or I mean, this is just a class average, so we're not saying how you performed individually here. But the class average was the same for optimism, empathy, and flexibility, and seems to have slightly increased for resilience and persistence. So that's interesting. We don't know why, other than maybe you're focusing on that stuff. I don't know. All right. Now I'd like to recap briefly on disorders from lecture 6, because in lecture 6 I lectured on health, stress, and disease or psychopathology. So this lecture on abnormal psychology is slightly overlapping with that one. So I'm just going into greater depth in different disorders in this lecture. Wakefield in 1992 defined disorder as a harmful dysfunction that, as judged by the standards of the culture, the harm may include significant internal anguish, so high levels of anxiety or depression, or problems in day-to-day living, for example, in one's social or work life. So keep that in mind. Harmful dysfunction. I think that's a popular and common way of thinking about disorder. It needs to be harmful either to the self or to others. And the APA definition or thoughts about disorder is that it's a condition that is said to consist of the following. There are significant disturbances in thoughts, feelings, and behaviors. The disturbances reflect some kind of biological, psychological, or developmental dysfunction. The disturbance leads to significant distress or disability in one's life. The disturbance does not represent expected or culturally approved responses to certain events. So the last one allows for some flexibility in the definitions of disorder across cultures, because some cultures will disagree with others about what represents an approved or expected way of expressing normal or abnormal behavior. And another recapping slide. This is the diathesis stress model. This is an important model because it's simple and powerful. So diathesis, first of all, it means predisposition. So if I have a diathesis for diabetes, that just means that I have a predisposition for diabetes. And that could mean, um, that my parents or family history includes that disease, or it could be that I have a predisposition based on my childhood or based on my ongoing diet for the last 10 years. So it doesn't matter what causes the predisposition. It's just that's what diathesis means. It just means predisposition. And then stress, you know what stress is. So this simple model specifies that there's only two necessary and sufficient conditions. And that's a key point, that it's necessary and sufficient. So you have to have both, and when you have both, that is enough for a disorder to occur. The causes of the diathesis can be biological, genetic or physical defects, or psychological, which can be like cognitive, social, developmental, and all the other kinds of psychology that we learn about. So wherever we learn about psychology and what we learn about how things can go wrong, that adds to the diathesis, the predisposition. And then there's the psychosocial, which is another, sometimes psychosocial is used to capture the psychological elements as well as the interactive elements that happen between an individual's own predispositions and their environment, both their physical environment and their social environment. So that's captured in the psychosocial word. Any questions? All right. Respecting mental disorders, your experience. I was just listening to an online conference, listening to I guess he's a well-known psychologist, not really psychologist, but a medical doctor who has started practicing psychotherapy. His name is Gabor Mate. Um, anyway, let me read the words on the slide. We must learn not to look down on those who live with mental disorders, because disorders are not the fault of the individual. They could happen to any of us. So Dr. Gabor Mate and others have pointed to the physical and pointed to the fact that physical and mental illnesses have their roots in societal problems or social causes. That means that if you look at someone with bipolar disorder or a phobia, the idea is that these disorders didn't happen on their own or due to poor choices that the individual made. It's all having to do with early life experiences, which are social problems, and childhood traumas. So childhood traumas can trace back to societal problems also, because we are raised by parents who themselves were raised by parents and were raised in a social context. So the parents are products of their society, of their environment and their world. And then you grow up with them, and in your environment and your world, it includes them as well as the greater social world. So problems don't arise in a void. They arise in a social context. So when we identify, oh, such and such has a problem, a mental problem, it could be, I mean, it invariably is due to causes in the surroundings, in the, I mean, yes, there is genetic susceptibility. That is a thing, but susceptibility is not the disorder itself. Susceptibility is the diathesis. So it's part of the diathesis. So susceptibility or diathesis is not purely genetic. So you cannot boil it down to everything is just genes in most cases. However, there are some illnesses that are due to genes, like Huntington's disease, but the majority of illnesses have complex causes that are contextualized in society, social context. All right, so I wanted to ask you guys, the class, if you have ever interacted with someone who had a mental health disorder, a mental illness, and what was that like, and what did you learn? So speak up, turn on your microphone, and please share with the class any experiences you've had. No one. So how about the next question? Have you ever lived with a mental disorder, and how long did you live with it? How did you recover? Can you teach us something about what it's like? I guess if you want to answer either of these questions, either your experience of others' mental disorders and your experience with mental disorder yourself.
I mean,
If
I
you've had
think
one.
I had a friend with a mental disorder, but she was never like diagnosed, so I don't think I should really speak up.
Um, I disagree. It doesn't matter if the friend was diagnosed or not. I'd like to hear about it. I think these are great, especially these informal experiences where you don't even know if it's diagnosed, but in hindsight, you can reflect and think, maybe it kind of looks like an illness. You don't have to name names or anything.
So she wasn't like always, she didn't always have the problem, but I guess after a lot of things happened, she started getting panic attacks in the middle of class. So we had to take her out of class sometimes, and she would like forget where she was once in a while, and she couldn't remember like what day it was all of a sudden.
Ah, that's interesting. The panic attack sounds pretty classic. I mean, straight from the book. What about the memory problems and the confusion? Maybe that's a direct result of the immense amount of stress and anxiety and fear.
Yeah.
When that happens, it can really overwhelm the whole um I mean, it's completely overwhelming. So it can leave so few attentional resources available for ongoing monitoring of where you are, what's going on. It can really interfere with memory and retrieval. Thank you. That's very interesting. Was that in high school?
Yeah, it was.
Right. Um, Good. Thank you. Anyone else?
I'm not really sure if this person had a disorder or not, but
Can you
basically,
speak up?
hello, can you hear me?
Yeah, that's better.
was visiting my cousins, their hometown, my grandparents, and one day we wanted to go play basketball. And like while we were playing basketball, like there was this guy, and he was just like standing quite awkwardly, and like he was super quiet. The reason he might have like a disorder or something is because he didn't talk a lot. He was very awkward. Like me like was I thought like maybe he had like some Down syndrome or like autism or something. But like either way, like we just still played um we just we just like gave him the ball and like played basketball.
So was he able to participate in the game?
A little bit, yeah. Like he didn't ask to join, but
Huh.
like he was just like standing in the side, like looking that he wants to join,
Huh.
but like, he didn't like ask. So like we just asked him if he wanted to join and gave him the ball, and he like just started playing with us. But like he didn't like bounce the ball. He would always just do this one, like he would just shoot the ball from like really far away, really hard. But like that's it. Like, cause like usually people would like try to bounce the ball and like come close and like shoot it really close. He always just like stand behind the line, like far away, and like shoot from far away, like really.
So you didn't quite discover what the exact disorder was. You just
Yeah.
knew something was off with this
Yeah.
individual.
Yes.
Right. Very good. And that's, I mean, that's the best you can do in that limited context where you just uh, right. Okay. So maybe if you got to see that same person in a variety of contexts, you would get a better idea of what was the exact nature of that disorder. But from that one limited context, you're left wondering, what was it? Was it Down syndrome? Was it schizophrenia? Was it immense anxiety? You don't know, right? Thank you. Anyone else?
Um, one of my cousin, um he rode a bicycle at night, right? And then it was really dark, so he couldn't see like an animal crossing the street. So he tried to like go another way to not hit it. So he fell over, and I'm not sure, like something happened with his brain, and like it couldn't function the way it was.
And was it like a permanent thing?
Yeah, it's a permanent thing. Like he
Ongoing.
had to, visit the doctor.
Ah, so any diagnosis?
Yeah, there's a diagnosis, but I couldn't remember like what happened.
Hmm,
But it's like an ongoing thing.
right. Can you characterize his behavior now?
Um, like he he could have a conversation with others, but like um it's not like a, how to say, like complete sentence. I mean,
Mm.
like the structure is not like what normal people would say, something like that. But like he could still understand what others tell him.
Hmm,
Yeah,
good,
something like that.
good. So it seems like the damage affected his output, his speech output, but not his comprehension. So that's great. If I had to
Yes.
lose comprehension uh, or output, I would rather lose output. Comprehension, ooh, that's so I'm glad that he was spared that. He can still understand people and interact in a some kind of logical, reasonable way. that makes sense, I hope.
Yeah.
Good, cool. So we've seen here that that mental disorders can have a blunt trauma cause. Well, I don't know if that's a mental disorder, the one you last described, but it's true that mental disorders can have a blunt trauma cause, or they can be, you know, there's genetic, there's disease, stroke, there's many different causes for different types of disorders and mental illnesses. Certain illnesses tend to have more, well, as we go through the lecture, you'll see that most of the disorders we cover are tend to have causes during the developmental years. All right, let's go on. So the Diagnostic and Statistical Manual of Mental Disorders is in its 5th edition. They're working on a 6th, but it's not out yet. And also, they're working on the ICD, which is the kind of equivalent of the DSM. So there's the DSM and there's the ICD. They're both kind of equivalent. They are used for diagnosing disorders. The DSM is used in America. The ICD is used throughout the world. I think they're working on the 11th edition of the ICD, and I believe that it's going to be so comprehensive and inclusive of everything in the DSM. It's kind of like a fusion of the two. So maybe we will not need the DSM in the future when the new ICD comes out. The ICD was released a preliminary version like a year ago, but it's not expected to be in widespread use for a while. I don't know why. I think it has to do with concerns about replacing previous editions and how that's going to affect insurance companies. I don't know why they're delaying its release, but maybe they're still accumulating more research for it. Anyway, so the DSM was developed in 1952 and has been revised every decade or two as we have evolved our understanding of disorders. For example, the DSM-3 dropped homosexuality in 1973, and the current DSM has dropped disorders that were mentioned in the previous DSM-4. So each subsequent edition continues to updates our understanding and cutting edge research and drops out outdated, poorly things that are not research supported, things that have caused confusion and problems, and more questions than helpful answers. So it's getting better. We are each version and the field itself of diagnosing illnesses is continuing to improve as we go decade by decade. Oh, and comorbidity is an important factor to consider. Let me read these words. The DSM provides categories of disorders, detailed descriptions, symptoms required for diagnosis and prevalence, of disorders, which means the percentage of the population that's afflicted. That's very important because if you are diagnosing someone with a disorder that occurs in only 1 in 1,000 people, you have to be a little more cautious and certain about your diagnosis because such rare disorders are unlikely, obviously. So the prevalence helps in the diagnosis. We should consider that more common illnesses are more it's more rational for us to suspect them and try to see, confirm. You know, there's confirmation bias, which is always a problem, but more prevalent disorders are also more likely, so they can guide and help us to yeah. You know, it's like this. If a person exhibits symptoms that fit perfectly well with a disorder that afflicts 10% of the population or another disorder that afflicts 1% of the population, that needs to be considered because it just makes more sense to diagnose with the more common illness. There's like 10 times more probability that it's that illness based on the prevalence in the population. So that's an important factor to consider that we're now considering because it's now that kind of information is provided in the diagnostic manuals. Risk factors and comorbidity. Comorbidity is an important word. Here's a couple examples to illustrate. OCD and major depressive disorder have a 41% comorbidity. That's huge. That's very big. So OCD causes a lot of stress and anxiety. And we know that stress and anxiety are risk factors for major depressive disorder. So we should not be surprised that they're comorbid. However, we don't say that OCD causes major depressive disorder, nor do we say that the latter causes the former. These are comorbid disorders, but we don't imply causality between them. So maybe anxiety is the common cause, the third factor, or maybe something else. Here's another example. Substance use disorder and any other disorder have 60% comorbidity. We don't want to assume that using illicit substances causes those other disorders, nor do we want to say that the disorders cause people to use substances or to misuse and abuse substances. However, if anything, the latter is more likely. But there may be these third factors that we don't know about. So we don't want to imply causality or assume causality accidentally when we hear about these comorbidity characteristics with disorders. All right, anxiety disorders. So now I'm going through, in this lecture, I have 11 disorders or classes of disorders to talk about, or maybe 10, anyway. So the first one, anxiety disorders. Anxiety is basically fear. They're not quite the same, but they are basically the same. So here's the difference. Anxiety is less certainty less imminency or immediacy, but they are both related to danger. Anxiety ought to be commensurate with threat. If your anxiety is much higher than the threat level, so for example, if there's a cockroach in the corner of the room and you're at the opposite end of the room, 20 meters away, screaming, then perhaps your anxiety is not commensurate with the threat. After all, the cockroach is not going to consume you or kill you. So when the anxiety is not commensurate with the threat, that's when we say that the anxiety might be a problem, when out of proportion with the threat, especially interfering with health, happiness, and goal pursuits. Anxiety is considered pathological when it gets to that point. I just saw the comment. Someone asked, what about Down syndrome? Is that a disorder? Good question. It was in at least some of the past diagnostic manuals. I don't know about the 5th diagnostic manual, but I imagine so, because the DSM continues to become more comprehensive and considerate and understanding, and reflects our growing integrated understanding of all mental disorders and illnesses. And I would say that Down syndrome is certainly one kind of disorder. So yeah, that should be in there. So yeah, anxiety is fear, fear is anxiety, but fear is more about an immediate threat, like if there's a bear chasing you or there's a spider crawling on you, then you're afraid. Then that's panic. But anxiety is more like, so the cockroach in the corner of the room could be called fear. But then if you are nervous to go back into the room in the future, even when you don't see the cockroach, then that's anxiety. Or if you're afraid that there may be cockroaches in other rooms, that's anxiety. It's lower grade and it's more prolonged or chronic. Most frequently occurring class of mental disorders is the anxiety disorders class. And I suspect that anxiety underlies many disorders. We know that anxiety is comorbid with depressive disorders and some others, but I suspect it's underlying a lot of disorders. In a year, around 23% of women, 14% of men will experience at least one anxiety disorder, often comorbid with other anxiety and mental disorders. I don't know why that gender difference is there. There are gender differences for all of the disorders in the diagnostic manual. You're always going to see that there's a percentage range for men and for women. And why is it different? We don't always know the answer. Sometimes we do. Sometimes it's a genetic thing because obviously men and women have different genes. Sometimes it's cultural because men and women are expected to think, act, and feel differently, and disorders are always related to how we think, act, and behave and feel, and as well as cultural expectations. So we should expect differences, but understanding why they're different or how. It's not always so clear. Anxiety to a specific thing or object or place is called a phobia. So a phobia is one type of anxiety disorder. A phobia means fear. That's what the word comes from French, I think, if I remember right. It is thought to be learned via classical conditioning, which is firsthand learning, or through social transmission, witnessing or being told other people's fears can be enough to acquire a phobia. So you may have never been bitten by a spider or snake, and yet you could still be very afraid of these things because of social transmission. So we've got phobias for heights, spiders, strangers, flying, enclosed spaces, blood, injections, snakes, dogs, and being buried alive. This is not a complete list. This is just, I mean, this is far from a complete list because people have phobias about so many things, but these are the common ones, I would say, the most common ones. And a question here, could fear of dangerous things be like an evolutionary thing? Most certainly. We know that's true for snakes. It's interesting that that we even need to learn our phobia for snakes through social transmission. If we don't learn it through that social transmission, we would just think, oh, how cute, and go run up and play with snakes. But we are so quick to learn through social transmission that snakes are something to be feared. And I think that our sensitivity to learning that fear is genetic and evolved and certainly adaptive for our survival. Thank you. Good question. Is social anxiety a phobia? Thank you for that question. Social anxiety is an anxiety disorder. We don't say it's a phobia. Well, that's a good question, because what's really the difference between a phobia and an anxiety? A phobia is specific to a thing, to an object, or a place, whereas social anxiety it can also be a phobia to, but it's not usually to a place or an object or a particular person. It's more general uh, to all people, or a larger variety of scenarios, places, contexts. So it's just a little bit too broad to be called a phobia, whereas phobias tend to be more specific to the feared object or thing or place. All right, so speaking of social anxiety, here are some anxiety disorders. First one may act in a humiliating or embarrassing way. The fear of that, the fear of acting in an embarrassing way can be the impetus or the cause of anxiety about being with others, especially more than one person at a time. So one-on-one may be okay for those with social anxiety uh, because in the worst case scenario, they cannot humiliate themselves to too many people at the same time. They can only humiliate themselves with one person. But maybe even one person being humiliated to that one person even could be enough to cause anxiety, unless they're really trusted and comfortable with that person. Can you see my video display? I got the, oh, it looks like, all right. So you can see my video now. 92% of adults with social anxiety reported a history of severe teasing in childhood. Okay, but isn't everyone teased in childhood? Well, apparently only 35% of a sample of adults with panic disorder reported that they were teased in childhood severely. So there may be some, I mean, it looks really clear, actually. That's pretty strong evidence. That's such a big difference that we would say that's a very highly probable cause or contributor to the susceptibility to social anxiety disorder is this being severely teased in childhood. How many of you were severely teased in childhood? I could raise my hand to that one. I was. Uh, and to be honest, I have, yeah. Um, to be honest, I do have a touch of social anxiety. So, so maybe, I think it's a pretty widespread phenomenon. Anyway, behavioral inhibition in early childhood, those who are timid, fearful, shy around unfamiliar people, is more than doubles the likelihood of observing symptoms of social anxiety, also called social phobia, in earlier years in adolescence. That was just one study. But so we see that there are these two markers, two forms of, two contributors to the diathesis of social anxiety. That natural, innate social inhibition, or sorry, behavioral inhibition, which is probably more genetic or early childhood causes. Whereas the teasing in childhood, severe teasing, is certainly an environmental social variable. So we see these different causes, these different contributors to the diathesis. Next one, panic disorder. This may be conditioned by recognizing symptoms from previous panic attacks. So the very first panic attack might have an unknown cause. We don't know why. You don't know why you had your first panic attack, but once you've had it, you could then be conditioned to develop a fear of that panic attack, because a panic attack is so stressful and psychologically, I don't know if you can, if you want to use the word painful, psychologically painful, but it's so uncomfortable that that the person who experiences a panic attack, then, because there was no warning and no known cause, they often don't know why they had it. So then they're afraid, what if this happens again? What if I don't want to be I don't want to have this happen again. So so the person who has one then could become afraid to have another one. Then that is a fear of the panic. The panic itself is like fear, so it becomes like a fear of fear. which can then develop into agoraphobia, which is the fear of the marketplace, literally, but really it is the fear of places where someone could not get help if they need help. Now, the student who shared about her classmate who got a panic attack in the classroom,
Yeah.
that who
That
was
in
that?
here.
Thank you. That the classroom is one of those places that people could have a panic attack. I know that it seems like, everyone's there, so it would be easy to get help. But I think counterbalancing with that is the fear of embarrassment. What if I had a panic attack in front of all of my peers? That would be horrible, right? So that fear of embarrassment is a fear, and that fear then feeds into no. The fear causes accelerated heart rate, accelerated breathing, and these internal symptoms of fear can be felt. And when you feel the development of these symptoms of fear, you then become afraid that you're going to have a panic attack. Then that fear feeds into the existing fear. It's a vicious cycle. So then, once you have a panic attack in front of your peers, you no longer want to be in front of your peers. So when you have a panic attack in the classroom, you don't want to be in the classroom anymore because you're afraid that you could have another panic attack.
Yeah, that was
So
exactly what happened. Whenever she felt like she was gonna get a panic attack, she used to just go away to an empty room and stay there until she got better because she said that staying in the classroom with the rest of us made it worse.
exactly, it does make it worse. You're describing exactly what I would expect. The classroom made it worse. Why? Because why do you why do you think that made it worse?
I think she might feel embarrassed to having a panic attack in front of her friends, and it's like loud, noisy, and quite hectic.
Exactly. Oh, she got worse when there was more noise, like loudness in the classroom.
Yeah, and just when there were people that she knew in general, because she said that she felt really embarrassed to have one in front of her friends.
Bingo. So it's that embarrassment and the fear of being embarrassed. The fear drives one into that vicious cycle. And it's interesting you mentioned that it was triggered especially when the class got noisy and boisterous.
Mm-hmm.
That's probably because she was um, I was just reminded of listening to some talks yesterday. I was reminded how different people have different thresholds of sensitivity to stimulation. Some people need a lot of stimulation to be comfortable, and some people need only a little stimulation to be comfortable. So the people that need a little bit tend to be introverted and tend to be quiet and seek calm, quiet places. Whereas those who are more extroverted and need more stimulation tend to hang out with friends and go to concerts and be surrounded with loud noises and music and stimulation, because that's what makes them feel comfortable. They have a different ideal threshold or ideal range of stimulation that they seek. sounds like your friend with the panic disorder really was overwhelmed with the stimulation of noise in the classroom, which would elevate her stress level, arousal, beyond her comfortable level, which would then throw her into susceptibility, which fueled with her social, her fear of looking, fear of embarrassment. Yep, it's the perfect storm. And she had a great solution to seek isolation, go into another room and calm down. That's the perfect thing to do. Neat to hear about that. The real world example. Thank you. The last one, general anxiety disorder. Freud explained it as free-floating anxiety. One fears all manner of things. So you could be, if you have general anxiety disorder, you might have social anxiety disorder also, but you also have maybe some phobias and you're afraid of public speaking, of public restrooms, you name it. There's, it's just like there's too many fears to be saying, oh, well, so and so has 250 phobias. No, when you have that many, you have something else. You have something called general anxiety disorder, which is that just general, you're going to be anxious about things in general. And so various everyday things, events, experiences, persons, objects will create the anxiety that will be centered on that at that moment, sort of landing on that thing. General anxiety disorder is a particularly troubling one. It's very hard to treat except with medication. Psychologists have had very limited success at curing GAD, as it's called, the acronym.
Mr. Jason, I
Yes.
wonder if panic disorder and anxiety disorder can also cause from the intake of medicine for other mental disorder.
Can cause the what?
Can panic disorder and anxiety disorder cause from intakes of medicine for another disorder? Like if one has depression, does the medicine that they take can also result in having panic disorder?
Unlikely, but possible. I don't know. Different medications have different side effects. And when you mentioned depressive disorder, I know that with bipolar disorder, and I'm not sure about, but maybe also various depressive disorders, often require not one medicine, but multiple medications. And these medications sometimes have to be adjusted up and down and balanced with one another just to get a just right mix of their effects on all kinds of neurotransmitter levels in the brain. Each medicine is a blunt instrument. It's like trying to paint a picture with a paint roller instead of a paintbrush. So when we are trying to alleviate a mental a depressive disorder with medications, sometimes not we, like, psychologists don't prescribe so much, but psychiatrists will test the doses up and adjust them up and down, trying to get, it's a bit of a trial and error thing. And it's possible, I guess it would be possible that too much of this and not enough of that could produce too much free-floating anxiety, which could look like general anxiety disorder or panic disorder. So I suspect yes, but I don't know.
Okay, thank you.
Thanks. I'd like to have a break now, so let's resume class at 2:10. Have a 10-minute break. Okay. All right, welcome back from the break. I'll get started with lecture now. Resuming from, next slide is on obsessive compulsive disorder. Obsessions are characterized as persistent, unintentional, unwanted thoughts and urges that are highly intrusive, unpleasant, and distressing. Concerns about germs and contamination, doubts, such as did I turn off the water, order symmetry, such as arranging all the spoons in a certain way, aggressive or lustful urges. Those are obsessions. Then there are compulsions that form part of the disorder as well. Compulsions are repetitive, ritualistic acts that primarily to minimize distress from obsessions or to reduce the likelihood of a feared event. Repeated extensive hand washing, cleaning, checking, such as is the door locked or not, ordering like pencils or spoons, counting or reciting something to oneself. In people with OCD or obsessive compulsive disorder, the orbitofrontal cortex becomes especially hyperactive when they are provoked with tasks such as looking at pictures hanging crookedly on the wall. So when they feel that anxiety about something that's out of order or something that they're uncomfortable with, an uncomfortable thought or uncomfortable state of the world, their orbitofrontal cortex is activated highly. So that suggests the orbitofrontal cortex has something to do with maybe the state of the world, how comfortable they are with the state of the world, or the desire to change or fix the state of the world. I'm not really sure. It's a little hard to say what each and every part of the brain does. It's easier to say what that part of the brain is involved in various experiences or events. Anyway, body dysmorphic disorder is one of the class of related disorders. In general, these disorders are related to a need for control and fear about the future. So they might be anxiety related. So anxiety issues might be comorbid or part of the diathesis of these disorders. Body dysmorphic disorder is the obsession with a perceived flaw. It's either one that does not really exist or that's barely noticeable. in physical appearance, particularly skin, face, hair, causing self-view as ugly or deformed. So something that threatens the self-image, that's and the physical self-image, that's body dysmorphic disorder. This drives repetitive and ritualistic behaviors and mental acts, constantly looking in the mirror, trying to hide the offending body part, comparing with other people, and getting cosmetic surgery. And then there's also hoarding disorder, which is classed in this class of disorders, the obsessive compulsive class of disorders. So it's a little confusing because OCD is a disorder in its own right, but then there's obsessive compulsive related disorders, which is a whole class of disorders that includes OCD. So the class contains the name of one member of the class. And then there's hoarding disorder, where one cannot bear to part with personal possessions, regardless of the value or utility, because it might be useful later or because they form a sentimental attachment to the item. I remember seeing and learning about someone who kept every single newspaper that they ever received for years and years, and their house was stacked with piles of newspapers. I think that's kind of like, I mean, obviously those old newspapers are not useful anymore. The person should know that, but there is a sentimental attachment, especially when you get into the collection building, when you're interested in the collection as a hobby. Then you could also be, maybe it starts as a hobby and becomes a hoarding disorder. I don't know, but it seems like it could be, because if it becomes a serious hobby, then you become anxious about missing or not having, because it, if you're building a collection, then each and every member of the collection is an integral part of the collection, and then you're afraid that you might that the value of the entire collection is compromised if you lose any single member of the collection. So I think that might be related to hoarding disorder, where the collection itself forms such great sentimental value. Sentimental value is just feeling that something has value. Sentiment means feeling. It also means clinging or attachment. So I think that hoarders have a specific type of attachment to that thing, whatever it is. I mean, that's pretty obvious. It's self-explanatory and definite. By definition, hoarders are attached particularly to their sentimental object, whatever it may be. Now, why is that called a disorder? Isn't it okay to be sentimental about objects? Yeah, it's okay, but I mean, it's okay to have fun collecting things, but it becomes a disorder when it impacts on your well-being, which it can start to do when it gets too extreme. The next one, post-traumatic stress disorder, PTSD. Symptoms include intrusive and distressing memories of the events, flashbacks, states that can last from a few seconds to several days. avoidance of stimuli connected to the event, persistent negative emotional states, fear, anger, guilt, shame, feelings of detachment from others, irritability, proneness to outbursts, exaggerated startle response. Nearly 21% of residents of areas affected by Hurricane Katrina suffered from PTSD 1 year following the hurricane. That's amazing. That's not 21% of sufferers of PTSD were still sufferers. That's 20% of the residents. So 1 in 5 residents, and this is 1 year later. So it's remarkably persistent and can be very chronic if it's not addressed. This is one disorder that when you get it, or if you get it, you want to treat it right away, and you want to treat it as aggressively as possible, because if you don't treat it, it could remain, well, I mean, it could spontaneously, you could have it spontaneously evaporate, which is called spontaneous remission. That happens a lot, but you don't want to risk it with PTSD, because it's if you don't spontaneously improve, you could be suffering with PTSD for a really long time, maybe the rest of your life. I mean, it 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 if it's going to go into spontaneous remission, it should do within a year. So I mean, within a few months, really. I mean, we could even say within a few days, because what are we talking about when we say should? The sooner you get better from it, the better. And this one is greatly improved with different therapeutic techniques. There's a lot of research on PTSD, and a lot of techniques are being tested, studied, and experimented with for PTSD. We already saw one of those when I showed you about virtual reality to count to as a form of desensitization to trauma from war, etc. For example, we first learned about PTSD from studying veterans, people, the men who came back from war. Now, next thing to say on this slide is that conditioning studies demonstrated facilitated acquisition of conditioned responses and delayed extinction of conditioned responses in people with PTSD. And this is not responses to the trauma. This is general conditioning ability. So it seems that people with PTSD are very good at being conditioned. That means they're good at learning behavioral conditioning or classical conditioning responses. This suggests that it is a form of behavioral learning, that PTSD is a learned response to trauma. And the trauma, when the trauma goes away, the learned response remains, and it's reinforced by itself. Every it's just like the panic disorder situation that I was telling you about before, where you notice the symptoms of stress in your heart rate and your physiology, and then you know, well, it's different than panic disorder, but it's kind of similar. The attacks of the ongoing stress response continue to to reinforce avoidance of certain activities, behaviors, places, which is part of the PTSD. Let me read to you some things some notes. So I have notes to read for all of these disorders that I'm talking about here. Social support following a traumatic event can reduce the likelihood and intensity of PTSD. A traumatic event can reduce the social support allows the sufferers, to discuss feelings and experiences, helping them to process the event and providing a sense of being loved and appreciated. For that reason, therapy should be very effective for those who are comfortable with therapy and interested in and willing to participate in it. Because therapy is but it doesn't have to be therapy. It's any kind of social support. So people who, friends, relatives, and neighbors who are caring and trusted, close, and can be trusted. Studies show sufferers who become involved in the community were less likely to develop PTSD, more likely to recover from PTSD. Any questions? All right. The next one, mood disorders. Depressive disorders are when people feel sad, discouraged, hopeless, no longer show interest or enjoyment in activities that previously were gratifying, such as hobbies, sports, sex, social events, time spent with family, and so on. So they have blunted pleasure. They can't experience pleasure. At the same time, they have elevated an exaggerated, magnified experience of sadness or pain. So major depressive disorder is one such mood disorder. It includes depressed mood for most of the day, nearly every day, with 5 of the following symptoms for at least a 2-week period. So if people have any 5 of the following: significant unintentional weight loss or gain, significant change in appetite, difficulty falling asleep or sleeping too much. Notice that it's not one or the other, it's either extreme. Sleeping too much or too little, eating too much or too little. So we see that depression upsets the natural balance. Difficulty falling asleep or sleeping too much, mentioned that one. Psychomotor agitation, so being fidgety, jittery, unable to sit still, pacing, hand wringing, pulling or rubbing skin, clothing, or other objects. Or its opposite, psychomotor retardation, which is the person talks and moves slowly, softly, or not at all, or very little talking, in a monotone, so without emotional expression. It's like they can barely connect with people or connect to feeling what they're talking about. They are seemingly disconnected from, well, perhaps they're disconnected from the pleasure that comes naturally from interacting with people. So they don't get pleasure from it, and also that retardation. I personally have experienced this a bit when I've been depressed, where everything seems to go slower, myself included. It's like, well, the passing of time really doesn't matter because there's nothing to look forward to. So why measure time? And then why measure time? Why rush? So it seems like perception of time slows down. So that might relate to this psychomotor retardation. Then there's also fatigue or loss of energy. Depressed people have no energy. It's 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 like a natural adaptive response. People that get sick also have fatigue or loss of energy, want to sleep a lot. And there's some speculation that depression is um, the natural response to illness as a way of resting and recuperating to recover. But that's just a speculative. That's just one model or one perspective. Anyway, feelings of worthlessness or guilt, difficulty concentrating, indecisiveness, and suicidal ideation. So if you have any 5 of these, I think for a 2-week period, yeah, then you could be diagnosed with a major depressive disorder, which is um, which is perhaps, I mean, it's hard to say that one disorder is worse than another, but this is a pretty bad one. The next one, the next mood disorder here is seasonal pattern, which is, I mean, it could be a major depressive disorder, but if it's of a seasonal pattern, then it seems to only come during one season of the year, usually fall or winter. And this is probably due to sunlight or lack of sunlight, to provide, I mean, it might be the timing of the circadian rhythm. So if your circadian rhythm is not being set properly, that might predispose you to depression. I have experienced that, the seasonal pattern, once, where I was living in a really cloudy area and there was very little sunshine that year. So I have experienced that. Peripartum onset, which is also called postpartum depression. That's when women experience major depression following pregnancy or 1 month following birth. They may feel guilty, agitated, weepy, not want to hold or care for their newborn. About 14% of women screened positive for this. That's a surprisingly high number. And it seems so maladaptive because right when you first give birth, your baby is, I mean, women, your baby is so susceptible, and the women are primary caregivers for their babies. So it seems very maladaptive that that there should be something called this depression right after giving birth, but it happens. So I would be surprised if this has happened throughout human history because it's so maladaptive for the survival of the infant, but it seems very prevalent in our modern era. It's an interesting thing. Uh, anyway, the next one is persistent depressive disorder, or dysthymia, as it was called before. This is depressed mood most of the day, nearly every day, for at least 2 years. Now, that's a long time to wait until diagnosis, but this is not as severe as major depressive disorder. So it's not full-fledged depression, but it's just not being as happy as normal, not being at the normal level emotionally, and it seems permanent. It doesn't go away, so it's constant, chronic. But people don't meet all the other major depression criteria. So if you meet the other criteria, then you have major depressive disorder, which can go on for 2 years if untreated. It doesn't usually last that long. It usually has a spontaneous remission within a few months. Sorry, within 6 to 8 to 9, 10 months, but that's a really long time, and sometimes it does go on for years. I'm talking about major depressive disorder. So if it's severe, it's major depressive disorder. If it's not as severe, then it's persistent depressive disorder. And the last one here on this slide is bipolar disorder, which is related. It's a mood disorder defined by mania. So if there's no mania, then it's not bipolar. If there's mania, you don't even have to measure whether depression happened or not, because the mania is a sufficient qualifying factor for the disorder, and it's almost inevitably swinging back and forth between mania and depression. So mania is the state of extreme elation or agitation. Elation means happiness, whereas agitation is discomfort with unusually high arousal. So whether you're happy and you're happy about being happy, or you're aroused and you're not happy about how aroused you are and you're kind of agitated and distressed by that arousal, that's a mania. And people with mania can talk a lot, as I seem to be doing, but that's on purpose because I'm giving a lecture. People behave recklessly or attempt to take on many tasks simultaneously. The diagnosis requires only one episode of a manic episode, which is a distinct period of abnormally and persistently elevated, expansive, irritable mood, abnormally and persistently increased activity or energy lasting at least 1 week. So it's interesting that you only need one manic episode to get the diagnosis. You don't need any evidence of depression, and it's only for 1 week that the mania spell only has to be present for 1 week, but then you have that disorder and that label for the rest of your life. But that's how it works, because maybe that's sufficient. Maybe that's well, because if you get it once, if you have a manic episode once, then perhaps you have the susceptibility to have it again when the right amount of stress comes into your life. It could throw you into another cycle of mania followed by depression, and it usually cycles back and forth until it spontaneously remisses or until treatment, usually with medication. During the manic episode, the person usually feels they're not ill and they don't need any treatment. So you can imagine that if you feel happy and you're just elated, you're excited and happy every day, you would not want to be treated. You would not think that you have a disorder. You would be very happy with your condition. So that's the case. A lot of people don't feel that they have a disorder when they're having their manic episode, but the mania is a problem because it disrupts their normal life. They can sometimes sabotage themselves and lead to problems that they then have to deal with for the rest of their life, such as, well, I'll read about it. Mania is preceded and followed by depression most of the time, usually. So I'm going to read some things about it. Bipolar. Around 90% of people with bipolar have a comorbid disorder, usually anxiety or substance abuse. Around 30% of individuals attempt suicide at least once in their lifetime. 15 to 20% complete suicide. Now that's a really high percent, which means if someone has bipolar disorder, they're at big risk of suicide, of actual, not just attempted suicide, but completed suicide. They're pretty serious about what they intend to do. While family members with bipolar, so having a family member with bipolar raises your risk of having bipolar 9 times. So there's a substantial genetic contributor. And more about the depressive disorders. They affect quality of life, obviously. They result in unavailability for work and education, abandonment of promising careers, lost wages. This affects 20% of women, 13% of men, at some point in in their lives. Comorbid disorders include anxiety and substance abuse. As I mentioned before, anxiety does go hand in hand with depression. Those two go together. A lot of research to support that. And here's some some more interesting information. When you have someone near to you, it could be a family member, friend, classmate, someone kind of close to you. If someone dies, has a divorce or separation, or family member leaves home, this can be a triggering event for a depression, especially if the event humiliates you. So if you have a breakup and the boyfriend or girlfriend blames you for the reason for the breakup, that can be a kind of humiliating, stressful event that can elevate your risk of depression more than 2 times the risk. Well, it elevates your risk of depression, and if the breakup is humiliating, then that raises your risk of depression even worse. Childhood, at least that's probably research done in a Western sample. I don't know what it would be in Thailand, for example, or more collectivist cultures. Childhood treatment or maltreatment and traumatic experiences before the age of 9, such as the separation from a parent or family turmoil or maltreatment, such as sexual abuse, can elevate the risk of chronic adult depression among those who have one short version or 2 short versions of the 5-HTT-LPR gene, whereas those who have 2 long versions of the same gene and have these traumatic experiences in childhood do not have increased risk of chronic depression in adulthood. So this is a very interesting and very clearly genetic diathesis for adult depression, owing back to the interaction between genes and early environment, social environment. The next disorder is schizophrenia. This is a psychotic disorder in which the person's thoughts, perceptions, behaviors, emotions are impaired, disrupted from the world in which we live. Main symptoms include hallucinations, delusions, disorganized thinking, disorganized motor behavior, and negative symptoms. Auditory hallucinations are the most common symptom. They happen in 2/3 of cases. Delusions are beliefs that that are contrary to reality and firmly held in the face of contradictory evidence. Paranoid delusions involve false belief that other people are plotting to get you. Grandiose delusions are the delusion that you hold special power or unique knowledge or you're extremely important. Somatic delusions are those that in which you think that something wrong is happening to your body. And here's an example, that your kidneys are being eaten by cockroaches. I thought that was a entertaining example that I read about. Disorganized thinking is another feature. This refers to disjointed, incoherent thought processes, usually detected by what a person says. They could be rambling or jumping from topic to topic. Another, or what seems like random combining of words. That's sometimes called word salad. But word salad is usually a feature of a speech problem with abnormal, like this a lesion in a certain part of the brain. But a bit of word salad, that's where you can't make sense of what the person's saying, even though their words are real words and you can understand their words. It's just that the words don't seem to go together and make sense. That reflects the disjointed and hard to understand associations that the person with schizophrenia is in their state of mind. So they can see, people with schizophrenia can see associations between things that the rest of us can't see. That's one way of seeing it, is that they see more associations than we do, but they can't communicate that in a way that makes sense to us. That's one interpretation. There's also tangentiality, which is the remarks that appear to be unrelated to what was said or asked. So if I ask you, what time is it? And you say, there's too many things in the room. I can't understand how that's related to my question, but someone with schizophrenia might think time and then relate that to something, and then relate that to something else, and then relate it to something in the room. So there may be these associations that we are just not privy to when we are not suffering from the disorder like they are. So we call it disorganized, disjointed, incoherent, which it is, but there may be some kind of logic or rationality there that we are not able to perceive. And then there's disorganized abnormal motor behavior, which is where the person behaves abnormally. They become unusually active. They might act childlike, giggling, self-absorbed smiling, or they might engage in repeated or purposeless movements or display odd facial expressions or gestures. In some cases, the person would exhibit catatonic behavior. So this used to be called catatonic schizophrenic state, where the person can become stiff as a board, or freeze while they're standing and just not move and not respond to their environment at all. What does that mean? I guess it means that they're engaging in some kind of completely internal experience where they're cut off from their experience of the outside world, but they're still engaged enough with their body to freeze it. I don't know what's going on internally. So there's like posturing, maintaining a rigid and bizarre posture for a long period of time, catatonic stupor, a complete lack of movement and verbal behavior. There's also negative symptoms. These are very important, but they're often missed or ignored. These are noticeable decreases and absences of certain behaviors, emotions, or drives. The diminished emotional expression is showing no emotional expressions, lack of speech, lack of movement, when such expressions are normal or expected. Avolition, meaning lack of volition. A means not or lack of. So avolition is a lack of motivation to engage in self-initiated and meaningful activity, including the most basic tasks such as bathing, grooming. And then there's alogia, which means not talking. There's asociality, which is social withdrawal, lack of interest in engaging in social interactions with others. Anhedonia, so a or an as a prefix means lack of. That's the inability to experience pleasure, just like depression. And a few things to read to you about schizophrenic disorder. The risk of schizophrenia is nearly 6 times greater if one has a parent with schizophrenia. Adoptees whose mother had schizophrenia and who had been raised in a disturbed family were more likely to develop schizophrenia or another psychotic disorder than those who were raised in a healthy environment. So if you had a schizophrenic parent and then you were adopted, so you're not raised with the parent, then you don't share any environment with the parent. You only have the genes. Then you're not so likely to develop schizophrenia unless that adoptive home was stressful. So if the adoptive home was good, then you're only about 5% likely to develop the disorder. But if it's a stressful home that you're adopted into, then you have a 36%, 37% chance of developing schizophrenia. So it's certainly, there's a strong genetic component, and it's also a very strong environmental or nurturing component to provide the diathesis or the stress that combines to make you have the disorder. An overabundance of dopamine in the limbic system may be responsible for some symptoms, such as the hallucinations and delusions, whereas low levels of dopamine in the prefrontal cortex might be responsible for the negative symptoms, avolition, alogia, anhedonia. In recent years, serotonin has received attention, and newer antipsychotic medications used to treat the disorder are working by blocking serotonin receptors. So it gets kind of complicated with these. Is it too much of this or too much of that? It really depends. It's like, but we're finding results that serotonin and dopamine are both related in complex ways. We need more or less of that in different parts of the brain. A new approach to identifying psychosis is called prodromal symptoms. These are where you have slight symptoms of the disorder, but you don't have the full-fledged disorder. And then this new approach is looking at people who have signs and symptoms of schizophrenia without having schizophrenia. So if you have symptoms like you might believe that the government is out to get people. Maybe not you particularly, but so you have like some kind of a paranoid delusion or any of these symptoms of schizophrenia. That those are prodromal if you don't have schizophrenia. Then what researchers are doing is looking at the genetic risks and these prodromal symptoms and then looking and watching your behavior and stress to see if um, to see how these prodromal symptoms and susceptibility interact with stress to trigger the onset of disorders, and maybe also to look at um, interventions with people who show these prodromal symptoms in order to prevent the later onset, to protect against the later onset that might have occurred with stress. So this is a promising and interesting future, a new approach to research in schizophrenia, using schizophrenia-like symptoms without the full-blown disorder. All right, so I've been lecturing and talking a lot and going kind of slow through the lecture, but let's take a 10-minute break. So it's 2:55. Come back at 3:05. Welcome back from the break. I will get started with lecture again. Dissociative disorders. Here are some examples, but they are characterized as individuals becoming split off, dissociated from the core sense of self. Memory and identity become disturbed without a known physical cause. So if there is a known physical cause, then we know it's not a dissociative disorder, just based on how we define and diagnose by our criteria and our definitions. So two examples are depersonalization or derealization disorder and dissociative identity disorder. The first one is recurring episodes of feeling unreal or detached from or unfamiliar with one's self or aspects of the self, where one might believe their thoughts and feelings are not their own. They may feel robotic, as though they're lacking in control over their movements and speech. They might experience a distorted sense of time, sense of unreality or detachment from or unfamiliarity with the world. They might feel as though in a fog or a dream, or that their surrounding world is somehow artificial or unreal. That's this disorder. It sounds kind of like schizophrenia, but and I wonder if people with schizophrenia may frequently experience, I'm sure they do experience depersonalization, but not by itself. So it's, yeah. Well, yeah. The next one is dissociative identity disorder. This has become very interesting and popular to people. So there's a lot of talk about it, but it's relatively rare. This is when a person manifests two or more separate personalities or identities, each well defined and distinct from one another. And they can experience memory gaps for time during which another identity is in charge. So they could find unfamiliar stuff in their shopping bag among their possessions, or among their possessions, or they could not remember how they got to where they are. That is similar to something called a dissociative fugue, which I'm going to read to you about here. Some with dissociative disorders experience a dissociative fugue, which means flee in French, where they suddenly wander away from their home and they experience confusion about their identity, and sometimes they adopt a new identity. Now, I was thinking about that some, and I decided that that makes a lot of sense about the formation of a new identity, because forming an identity is very spontaneous and natural. And if you cannot remember your identity, it doesn't take long to start building a new identity. It's hard to exist without an identity. So if we have a disruption of identity through some dissociation, then I expect, and I'm not surprised that someone would spontaneously start generating or inventing or creating a new identity. So that's what happens sometimes with this dissociative fugue and these dissociative disorders. Most fugue episodes last only a few hours. 95% of people with the dissociative identity disorder that I mentioned here on the slide, 95% of them were physically or sexually abused as children. That's a very high percentage. Now you might wonder, well, how can we trust them? Because people with dissociative identity disorder often act out of character from their normal self, whatever that is, which can include lying. But apparently, I mean, if we can believe these numbers, 95% of them were mistreated as children. So this is, again, adds to our understanding that the disorder has a diathesis owing to not just genes, but nurturing, and that early childhood experiences, especially trauma, is related to so many disorders, this being one of them. So if all of these disorders have their diathesis in childhood trauma, then why is it that mistreated children don't all go to develop dissociative identity disorder? Some of them develop this, some of them develop that, some develop another thing. It's probably because of the way I think about it is the genes may set the individual up to develop this disorder first, and if this disorder were not uh, susceptible due to genetic predisposition, then it would be another disorder. And so it's whichever disorder is first to come up in the genes. So you might have a susceptibility to dissociative identity disorder and bipolar, but bipolar might be more easily triggered. So it can be triggered with less stress or and so forth. So certainly the diathesis includes genes and stress and childhood trauma. The childhood trauma is not does not dictate which disorder you're going to have, but it predisposes you to a disorder. And then the genes kind of like suggest which disorder it would be. 9% of the US population suffers from a sorry, that's the next one. Okay, so the next disorder is personality disorders. This is a class of disorders. There's 10 of them. Personality is a stable, consistent, and distinctive way of thinking, feeling, acting, and relating to the world. A person with a personality disorder exhibits a personality style that differs from the expected in their culture, is pervasive, inflexible, begins in adolescence or early adulthood, and causes distress or impairment, which frequently brings them into conflict with others, disrupts their ability to develop and maintain social relationships, and prevents them from accomplishing realistic goals. So we all have personalities, we all have personas, just like we all have identities. But the personality becomes a disorder when it interferes with your ability to maintain social relationships and causes stress in others and in yourself. So, just like any of the other disorders. So there used to be more than 10, but the current version of the DSM has been boiling these disorders down to a finite number, to a smaller number. And now we have these disorders classed into 3 clusters because lots of personality disorders with their different names share features, and we can kind of group them together for their features. So the cluster A is for odd or eccentric personalities. These include paranoid, schizoid, and schizotypal personality disorders. I'm not going to define all of these because I think it's a bit much to go into that much detail with all of these. There's cluster B, which are characterized by impulsive, overly dramatic, highly emotional, and erratic. These include antisocial, histrionic, narcissistic, and borderline personality disorders. Cluster C is those who have nervous and fearful personalities. These include avoidant, dependent, and obsessive compulsive personality disorders. So it's quite interesting that there's the obsessive compulsive disorder, class of disorders, and personality disorder, which is different. Each of them is different from the others. So you don't have to know what these personalities are like. You don't have to remember that they're which cluster they're in. You don't have to memorize cluster A, B, C or their characteristics. You just have to know that these are that personality disorders exist, that there's 10 of them, and that they're recognized in our current DSM, Diagnostic Statistical Manual, which is the dominant source for research purposes. And I would like to add that 9% of the population suffers from a personality disorder in the US, with avoidant and schizoid disorders are the most common. Borderline personality disorder and antisocial personality disorder are regarded as especially problematic or troubling to the person and their others. Individuals with borderline personality disorder report experiencing childhood physical and sexual trauma or emotional abuse at rates far greater than those observed in the general population. So that kind of childhood trauma predisposes one to borderline personality disorder. So of the personality disorders, that one has a childhood trauma cause, whereas the other 9 personality disorders, I guess we don't know as much about their cause. One more thing I'd like to add about personality disorders is that they are very chronic, very persistent. They're basically lifelong sentences. So if you have the personality disorder, that is fairly resistant to therapy. And we don't usually prescribe medications for, well, I can't say that for sure. Yeah, they're persistent chronic disorders, and they're generally immune to therapeutic interventions.
So can like what is classed as a personality disorder depend on the culture?
Great question. I would be very surprised if the rates of these personality disorders were the same across all cultures. In fact, I'm suspecting that some of these personality disorders may not even exist in some cultures. They're probably very influenced by the culture. For example, narcissistic personality disorder is probably particularly particular to individualistic cultures. That's my own thinking. I don't know this. Like, I haven't studied the research to know for sure. But knowing what the qualities are, I can assume that. And different cultures with their different ways of thinking and behaving and feeling predispose people to different disorders. And I'm fairly certain that personality disorders are no exception.
Thank you.
Thanks. All right, we're getting toward the end of the lecture here. Neurodevelopmental disorders are those that occur in childhood. So they used to be called childhood disorders. Now we're calling them the names of these disorders change from decade to decade as these diagnostic statistical manual editions get revised and the research and people know more and more about them. The names end up changing. So these are diagnosed. These neurodevelopmental disorders are diagnosed in childhood. They involve developmental problems in personal, social, academic, and intellectual functioning. 2 examples are attention deficit or ADHD and autism spectrum disorder. So ADHD, I'm going to talk about here. Many hyperactive children are those that are fidgety, restless, disruptive, socially disruptive, trouble with impulse control. They also display short attention span. So their hyperactive status or their hyperactive symptoms may be a product of or a cause of their attention spans being short. So they have problems with concentration and distractibility. ADHD is one of these disorders that's on the rise, along with the other of these neurodevelopmental disorders. Autism disorder is also on the rise. I'm sure you know that. This is if you don't know it, it's been talked about in the press, at least in psychological circles. It's disturbing, the fact that these things are on the rise. such a rapid rise, which has triggered researchers to look at changes in diet and pollution, and we're wondering why are these disorders on the rise so rapidly. And I can say that that's partly because we know more about it, so we can recognize it better. We have more clinicians to diagnose it. The more we know about it and diagnose it, the more that we can recognize cases that we previously wouldn't have recognized. So yeah, that's a big factor. But we don't know. There might also be, one theory is that as our technology becomes more and more in our hands, so we have our mobile phones and devices always able to that we can always access and to stimulate ourselves and take our attention, we might be less able to sustain attention for longer periods of time. That's one theory. That's not proven yet. We don't know if that's at all related to the rising rates of ADHD and autism. So we still don't know what's driving these rates of rapid increase, but anyway. Signs of inattention include great difficulty with and avoidance of tasks that require sustained attention. So if you have attentional deficit, then you don't really want to get yourself in a situation where you have to pay attention for long periods of time. So you might not like going to school or talking with adults, because adults may talk on and so on. Reading might be hard because that requires sustained attention to make sense of what you're reading. Failure to follow instructions, such as completing schoolwork. Disorganization, such as keeping hard keeping things in order, poor time management, sloppy work. There's lack of attention to detail, becoming easily distracted and forgetful. Forgetfulness is to be expected because to remember something requires a lot of attention. If you don't pay attention, you don't remember. And then there's the hyperactivity component of the name. That's characterized by excessive movement, including fidgeting, squirming, leaving one's seat in situations where you're expected to remain in your seat, having trouble sitting still, like in a restaurant, running around and climbing on things, blurting out responses, interrupting people before they fully ask their question, difficulty waiting your turn for something, interrupting, intruding on others, noisy and boisterous. Behaviors are hasty, impulsive, and seem to occur without much forethought. ADHD is chronic. It persists into adolescence and adulthood. And I have some things to talk about, to read to you about ADHD. Those adolescents and young adults diagnosed with ADHD receive more traffic tickets, have more automobile accidents, and this occurs in about 5% of children today. Those with ADHD have lower grades and lower standardized test scores, not because they're dumber, but because their intelligence may not be measurable on tests that require sustained attention. They're less well liked. They're more often rejected by their peers. About 30% of adults who have been diagnosed with ADHD decades earlier still show signs of ADHD, you might consider testing yourself or seeing whether you could be diagnosed with ADHD. Not that it matters. I mean, if you want to know, you can. People exhibit, those with ADHD, children, exhibit smaller frontal lobe volume, but beware assumptions of causality. We don't know if that's because we don't know what's causing that. And they show less frontal lobe activation when performing mental tasks. So my take on that is the frontal lobe, which is involved in higher level reasoning, requires sustained attention for prolonged thinking about things. So there is that limitation to. All right. Maternal smoking during pregnancy is associated with more severe symptoms with the development of autism. With ADHD, as well as more severe symptoms. And it's triggered by more genetic and neurological factors and less by social and environmental factors. So we're not seeing as much the nurture part of this contributor. We're seeing a lot of the the genetic nature part. Adults with ADHD are more likely to drop out from high school, less likely to have earned a bachelor degree. They have lower socioeconomic status, less prestigious occupations, less likely to be employed. They earn less salary. They score lower in occupational functioning, lower job satisfaction, poorer work relationships, more firing, worse on measures of social functioning, more likely to get divorced, more likely to have substance abuse problems, drinking problems, smoking, use of marijuana and other illicit drugs, show less dopamine in key regions of the brain, and lower in the regions that are associated with motivation and reward. So a whole bunch of things. So it's quite a to say. I kind of didn't like to use the word curse, but it's quite a curse to be to have it. But it's not very common. I mean, it's kind of common, 5% of children. And then it's not really something that you grow out of. You have it. I assume you have it all your life, but adults tend to manage their symptoms better. So they probably mask their symptoms better or compensate or somehow maybe they can overcome their symptoms to some extent. But adults will show signs that they have it. So it's not like you really permanently grow out of it once you become an adult, but the symptoms are less severe, maybe more masked. Anyway, a lot of successful people have it and cope with it. So just because you have it doesn't mean you're cursed for the rest of your life. You really you can still make of your life what you will. It's not a completely disabling disorder. Autism is the next one. This one's more severe, and this one is also on the rise. Children with autism spectrum disorder. We call it spectrum disorder now because we recognize that that it comes in degrees, and also that the high functioning and the low functioning, they both exhibit the same symptoms. So it's really, so I'm glad that we're calling it spectrum. And it also, well, let me read the words here on the slide. Those with the disorder have significant disturbances in three main areas. There's deficits in social interaction, communication, and repetitive patterns. They do not make eye contact with others. That's probably one of the biggest giveaways. But now, through therapy, autistic people are being trained to make eye contact, even if it's not their natural inclination, just to act like they're normal, just to fit in, I should say, to act like they're neurotypical. That's the politically correct way to talk now. So they don't make eye contact with others. They seem to prefer playing alone rather than with others. Their communication deficits range from complete lack of speech. So there's some autistic people who will not talk at all. And they don't know language. They never learned it. Those are the most severe. On the spectrum, then it ranges to difficulty maintaining a conversation and problems in using and understanding nonverbal cues. So it's not just speaking that's the problem, it's communication. Communication is the problem. So there's deficits in facial expressions, gestures, and postures that all go into the verbal and the nonverbal elements of communication that facilitate normal communication. Repetitive dropping of an object and then picking it up is one kind of a repetitive movement example. Like stereotyped repetitive movements, head banging, rocking, like just over and over for, could be hours. Children may show great distress at small changes in routines in the environment, highly restricted and fixated interests. They could memorize a bunch of details that seem to be like there's no reason to do that. It's not the same as intellectual disability, but it's often comorbid with intellectual disability. Going back to the rocking and headbanging and dropping objects, picking them up, I was told that these activities are thought of as stimulating activities. So the one with autism spectrum disorder may lack stimulation, especially because they're so socially isolated in their own social world, or in their own world that's devoid of sociality. They might have a lack of stimulation, and they make up for that with these kind of repetitive tasks that they can do while they zone out from doing them, but that nonetheless continue to provide stimulation. So rocking back and forth provides the sense of balance stimulation. And if it's constant and repetitive, it can be done without thinking about it. So without attention, yet still deriving that stimulation. So there may be some benefit to that. So don't think that someone with autism spectrum disorder that's rocking back and forth is necessarily suffering from an intellectual disability. They might just be self-stimulating, as it's called, especially in childhood. We used to diagnose people as either autistic or having Asperger's, but now we recognize that Asperger's is really not different than autism. It is autism. It's just high functioning, and particularly high functioning with speech. but speech is really a key core feature of autism spectrum disorder. So the high functioning ones are less susceptible to communication disorder, so they will pick up language better. So those who were previously diagnosed as Asperger's will be currently diagnosed as autism spectrum disorder at the high functioning level. They will still have trouble making eye contact and holding eye contact because there's nothing of interest to them looking at other people's eyes. Right. So those with better language skills can live and work independently as adults, but those without language skills tend to have more severe symptoms all over, and they tend to be unable to lead independent lives. So they end up living with their parents or with caregivers in an institution and so forth. And some additional details about neurodevelopmental disorders. With autism, 1 in 88 children in the United States has autism. The disorder is 5 times more common in boys than in girls. So in boys, it's 1 out of 54 boys. And girls, 1 out of 252 girls. The rates of autism spectrum disorder have increased dramatically since the 80s. For example, California saw an increase of 273% in the cases reported between 1987 and 1998. So that's a 12-year period. During that 12-year period, there was a nearly 3 times increase in diagnosis of this disorder. Again, that might be due to greater recognition of it, greater ability. So more cases of parents bringing their children to get diagnosed, but it might be more than that. Autism is strongly influenced by genes. Okay, that concludes this lecture. Next week, I would like to do something very experimental. I'd like to have class in the park. I've never done this before, but I've been thinking about it for much of this semester. So I'm going with it, especially for next week, because I will not have to rely so much on my electronics for giving a lecture, because, well, I'll explain. So here's where the picture in the background of this slide is exactly where I want to hold the lecture. I've scoped it out and identified that this is a really quite suitable place for holding a lecture while we are still able to physically distance from one another. So there's the address. However, I hope it doesn't rain, but if it rains, we're just gonna have to go back to Zoom. If it's a light sprinkle, maybe we'll just bring umbrellas, yeah? All right, then wear your mask. And I use the word social distance because that's the common term, but physical distance is a preferable term. I like that better. Just learned that term recently. Physical distance just makes more sense, because we don't want to socially distance each other, like be less close emotionally, socially. We want to maintain our social relationships and closeness while physically distancing. So you will share in groups about your self-created projects. They are going to be due on that day. So everyone would have completed and looked at their results and analyzed and detected whether they've made progress or not. Also, I'd like to make a special point about your self-created project. I want you to grade yourself more on effort, less on accomplishment. Because I know a lot of you are inclined to grade yourself based on how well you did, but I want you to grade yourself more on how consistent you were. So try to measure your consistency. Try to adjust your grading. I mean, I already gave you feedback on this on your proposal. Just make sure that you don't neglect that feedback. I want you to grade yourself on your consistency of accomplishing what you set out to do. And then if you can incorporate a little bit of like your accomplishments into your grade, you can do that if you want. I will deliver a 1-paragraph summary of each lecture that I've ever given in this course to review the course. So I'll deliver that here in the park. And reminder that your insight journals and your self-created assignments are due on that day on Blackboard. Okay. Any questions?
For the submission for your self-assignment, do we have to are there any requirements for the doc itself? Like, is there a limit on pages? Should we show evidence of what we did?
Thank you. I like graphs. I like tables, diagrams, maybe pictures if it's relevant. But mostly I'm looking for words. And I want, there's no page limit. It could be short or long. I just want you to follow the instructions in the syllabus, the details for this assignment. But basically, I just want you to tell me about it. So there's very little formatting instructions or length. There's no length requirements. Any other questions? Someone asked, is a table or graph required? No, you're not required. No. It really depends on the project. So I think that tables are common for this kind of project. So you could provide a kind of a table or graph to document and graphically illustrate your consistency or your progress. And that's really nice and helpful, but it's not required. So just do what's suitable for your individual project. Someone asked, do you have to wear a uniform? That's a really good question because we're not technically in a classroom. So I'm going to say no. But I can still encourage you to wear a uniform because this is still a university class. So it's kind of like in keeping with the spirit, but it's not in the classroom and it's not using any of the institution's buildings. It's an open park, so feel free to wear whatever you like. Maybe bring an umbrella if you want to sit over on the sunny side or if there's not enough space. But there's also a lot of shade under these trees. And I'm going to divide you into groups during that day so you can find a shady spot so you don't have to worry too much about the sun.
Will it be at 1 p.m.?
Yes, it will be at 1 p.m. So please come on time. Don't come late. So you might want to come a little early because I'll try to start class at or shortly after 1 p.m. And I'll start with you in groups talking about your self-created projects. Any other questions? I'm reading about one student says she experienced a panic attack not long before the midterm and it was horrible. I'm so sorry to hear that. Panic attacks are the worst. They're really bad. I've had sort of one. I mean, it was bordering on a panic attack. Or maybe it was a panic attack. I didn't realize that it was. It can be, I mean, it's like there's no escape because you can't escape it physically. I mean, we heard about that girl in the classroom that she can escape the classroom and go to her own private area where she can calm down, and that's very helpful. But that's almost kind of like leading up to the panic attack, whereas the panic itself, once the attack comes, it's almost like you can't escape from it. But sorry, that was just an aside because I was reading the chat box question. This was a private message to me. Anything else? Any other questions? Next slide. In 2 weeks, you're going to have your final exam. It's going to be held during regular class time on Blackboard, and it's timed. You might not think like, what? Can Blackboard give exams? Yes, Blackboard can give exams. I've never used Blackboard for giving an exam, but it can be done and I'm gonna do it. So it's gonna be mostly multiple choice, maybe some short answer. There's gonna be a time limit to reduce your ability to consult lecture notes and internet sources because I want you to still study your lecture notes, my lecture notes. I'm sorry, the slides. I want you to study my slides to prepare for the exam. But on the day of the exam, you can use the internet and you can use the slides to look up stuff that you forgot. So I really don't encourage memorization, but I do encourage you studying and understanding because if you try to answer all the exam questions by frantically looking up and trying to cram while you're taking the exam, you're going to run out of time. It's not effective. So I do expect and encourage and suggest that you prepare for the exam in advance before taking it. So read to understand, not to memorize. My rules for the exam. This is the first time I'm doing it on Blackboard. So here are my rules. Blackboard exam rules. Work alone. Don't consult others during the exam. And to monitor you, I will require and take record on Zoom, and I will be noting. I will require all students to turn on their cameras, but mute your microphones. So I will be watching all of you take the exam while you're taking it, and I will observe to ensure every student is working alone and not talking, because I know that you could be, you could hold your phone on a desk and be moving your lips, especially with a mask on. So I should say, don't wear a mask also. I don't want you communicating with anyone during the exam. So keep your camera on during the entirety of the exam to receive full credit. If you disappear or turn your camera off or cover your camera, then I'm going to take special interest in that and penalize your exam results based on your behavior during the exam. Does that make sense? Hope so. A couple questions in the chat box. Yes, you're going to present your self-created assignments in groups rather than to the entire whole class. So I'm going to split you up into groups, say groups of 5 or 6 to share with each other about your self-created assignments. The exam is open book. Even though I said it wasn't before, it really is. So it is, yes. How long does the exam take? That I have not decided yet. But normally the exam takes 2 hours. If you, here's a question. If you need to use the toilet during the exam, what should you do? I didn't anticipate this, so I'm deciding right now. You should privately message me asking for permission, and I will answer you, yes, you have permission, and then you can go, and I will watch and monitor the time and expect you to be back within a minute or two. Yeah. The groups next week, when you're grouping together for talking about your your self-created project, I will let you choose your own groups for that. So feel free to just decide next week when we get there or whatever. Okay, what else? Here's another question. Any other questions? Looks like there's no other question yet. The park, I don't think there's a public restroom in the park, so you'd have to exit the park and go next door to I'm Park building to find a restroom in there. But yeah, if you know where I'm Park is, then it's the park right next to it. Let's see. How many questions on the final exam? The questions, there will be somewhere between 50 to 70 questions. I haven't decided exactly. There might be fewer, there might be more. Probably not more. I don't like long exams. And I expect you to finish the exam probably within about an hour, but I'll give a fair amount of time. So probably 2 hours for an exam if there's like 65 questions on it or something like that. Any other questions? Okay. Oh, here's one. Oh, if you cannot attend class next week, then you simply cannot attend. There's no strong penalty for that. In fact, well, yeah, I'd like to take record, and I'll give you laboratory credit for attending class. It's 1 point, just like every lab assignment is 1 point. So there is a small benefit of attending, but if you can't make it, it's okay. It's just a missed point. No page limit for the self-created assignment. Yeah.
So like in the exam rule, you say that like if we appear to be talking during exam, then we will be penalized, right? But if I talk to myself, how could you realize that I was talking to myself or I was talking to someone else?
If you talk to yourself, I think I can tell, but I would probably message you privately, and I would ask, I don't know, what would I do? Let's see. I would ask you, are you talking to yourself? And if you answer back and say, yeah, I'm talking to myself, then I would let it go. Any other questions?
No, just that. Thank you. Because like I usually talk to myself during exams because like it helped me like bring out the memory.
Cool. You know what? That's totally cool, and that's understandable, especially because self-talk can help you focus. Like sometimes when you're reading silently, your mind can wander, but when you talk out loud, you can. Oh, another case is children will self-talk to help them think, and I guess actually that's still true in adulthood. It's just that adults tend to self-monitor and kind of like not do it because out of embarrassment. But yeah, self-talk really does help us think. I found that it helps me think sometimes about difficult, complex things. So yeah, good point. Feel free to self-talk during the exam, and I'll just make sure that I don't penalize you falsely. I'll try to like follow up and see if you're talking to anyone else, but feel free to do that.
Thank you.
Yeah, thanks. Thanks for asking. Okay, any other questions or thoughts? If not, I will see you in the park next week. All right, bye. Oh, and there's no laboratory assignment today. Oh, let's see. Is there anything else? Look, oh, one more slide here. No lab assignment. We already did a role-playing activity with mental disorders back in week 6. Optional is on your own if you want to. You can take a 15 to 20-minute informal assessment of your own mental health for educational and entertainment purposes at that website. And that is the end of the lecture.
Thank you.
All right. Thank you guys for coming.
Thank you.
Thank you.
And see you next week. Bye.
Thank you.